I have the privilege of introducing our next panel moderator, Lisa Kennedy Sheldon. So Lisa is the Chief Clinical Officer at the Oncology Nursing Society, CNS, where she oversees the clinical strategy for the organization. She hails for many years from my hometown, University of Massachusetts in Boston, where she taught nursing at the undergraduate, graduate, and doctoral level, training the next generation of nurses across our country, and continues to practice as an oncology nurse herself. She is active nationally in the National Cancer Policy Forum here in Washington, D.C., and co-chaired last November the workshop on oncology navigation that was sponsored by the National Academy. So without further ado, I'm going to bring Lisa up for her to moderate our next session.
Thank you, Tracy. Good morning. It is an honor to be here with all of you. I feel like I'm in the who's who of navigation here in the room. So thank you for allowing me to be part of the meeting today. In this session, we're going to have an opportunity to hear from 3 national organizations, leaders sitting right here with us to talk about what's going on from the viewpoint of CMS and the oncology care model, the Biden Cancer Initiative, and then and excuse me for that lack of coffee this morning, and the Commission on Cancer. So we're gonna introduce people one at a time, and they're gonna have a brief presentation, about 10 or 15 minutes, and then we're going to have an opportunity for discussion. So the questions that you've been holding back and wishing you could ask or didn't have time to last time, or you don't have a Southern accent, now's your chance. So our first presenter, and he's going to be talking with you rather than using slides, is Dr. Ron Kline. Ron is a board-certified pediatric hematologist oncologist for the last 25 years and a medical officer at the Patient Care Models Group at the Center for Medicare and Medicaid Innovation. Probably you know him best as the clinical lead for the Oncology Care Model and Medical Care Choices. He's a part of the team that developed the report to Congress on alternative payment models for radiation oncology services. Currently, in addition to his work on the OCM and the MCCM, he supports development of new physician-focused specialty models. He is previously a CMS representative to Vice President Biden's Cancer Moonshot Initiative and a Robert Wood Johnson Health Policy Fellow. Please help me in welcoming Ron Kline.
Good morning, everyone. Thank you so much for getting me out of the office, away from my cubicle, inviting me to talk about my favorite topic, which is the oncology care model. Thought what I'd do is spend a few minutes talking about what the oncology care model is, and then speak a little bit about some of the efforts of the oncology care model in patient navigation, and those are relatively high-level requirements. I think one of the things about the oncology care model, one of the things about government policy is, we try not to be prescriptive. We sort of let 1,000 flowers bloom, create a model, create a requirement to say you need to do this, and then let people figure out for their unique set of circumstances, based on practice, based on geography, based on individual patients, what the right thing is to do in terms of navigation. So for those of you who don't know the oncology care model, and I can't believe that anybody in this room doesn't know about the oncology care model, so forgive me for repeating things. It is a program at CMS, at Innovation Center, that was started in 2016, and it basically changes the way that we pay for cancer care in the United States. There are about 175 practices that are participating, about 150,000 unique beneficiaries each year, which translates into about 20% of every Medicare beneficiary receiving chemotherapy for cancer in the United States as part of fee-for-service is in the oncology care model. And so one of the neat things, and not so much at this session, but at other meetings you go to, basically it's the thing that people talk about in terms of how oncology care is changing in the United States. Not, once you get past the biology, which is obviously important, it's how do we deliver care, and OCM is probably the biggest thing happening right now, so it's always fun to play in that sandbox. So what is OCM? Started in 2016, and it's a two-part payment model. So it's triggered by, they're 6-month episodes of care. They're triggered by the receipt of chemotherapy, either oral or IV. And you can trigger repeated 6-month episodes as long as you continue to receive chemotherapy. And once you're triggering an episode, you receive $160 per beneficiary per month payment from CMS, which we call the MEOS payment, MEOS, or the Monthly Enhanced Oncology Services payment. And that payment was designed to help practices create the infrastructure to provide the enhanced services that we require them to deliver to OCM beneficiaries. And those 6 enhanced services are 24/7 access to a clinician with access to the patient's medical records. I think that's pretty much of a low lift for most oncology practices. I think if you're oncology, you're probably available to your patient 24 hours a day. It's not like some general pediatric practices where it's like you get a voice message machine that says, if you're sick, go to the ER and call us in the morning. I think one of the second enhanced services are providing the core functions of patient navigation. That's what's relevant to this group. And again, as I said before, we don't really specify how you provide those. I think early on in the model design, it was you have to hire a patient navigator. And we sort of changed that a little bit and said, you really don't need to hire a person. You need to provide the function. And if you're a small practice and it's your primary nurse who's providing the care navigation functions for their primary patients, that's fine. If it's the front desk who's helping organize scans, that's fine too. As long as you're providing the service, we're not going to tell you how to do it. Third is using EMRs, our favorite topic of all. And for those of you who missed it, there was a great article by Atul Gawande in the New Yorker about using EHRs. Very, very well-balanced, thoughtful article. I was just talking to my wife this morning, and one of the most amazing things about this, and I won't go off on a tangent on EHRs, was that Partners Health, which switched to Epic, estimated a $1.6 billion cost in switching to EMRs. And I said, wow, Epic's getting a lot of money out of that, $1.6 billion. And he went on in the article and said, $100 million was the cost of the EMR, and $1.5 billion was the estimate in lost productivity in terms of seeing patients. So, welcome to EMRs. That's not an official CMS statement. So that's a cranky doctor statement. What our other enhancement is we have to document a care plan for every patient that contains the 13 components of the Institute of Medicine's Cancer Care Management Plan. So IO had a report, I think, in 2013 that said, here are the 13 things that every cancer patient should have. Advanced care planning, survivorship care planning, discussion of prognosis, discussions of the intent of treatment, psychosocial support. And I think one of the most important things in that is documentation of financial toxicity, which we were talking about before as to how important it is. So one of the neat things about government, in terms of your ability to change the world a little bit, at least to change the world in the United States, is we just decreed that if you're participating in our model, if you're getting that $160 per beneficiary per month payment, one of the requirements of the model is that you're discussing out-of-pocket costs with your patients. So again, fun. I was in private practice for 25 years, in government for 4. It's like, wow, this is cool. I get to change the cancer world in the United States. We get to address a very, very important issue. Fifth is treating patients with therapies consistent with nationally recognized guidelines, and 6 is utilizing data for continuous quality improvement. So one of the things we do is send patients a quarterly feedback report about how their use of inpatient, radiology, different medications, ER, how it compares over time and how it compares to others in OCM and others outside of OCM. So we're giving people feedback data that they've never had before. So what is a two-part payment system? So it's that first part, which are the monthly enhanced, the MEOS payments, and then the other part are what we call performance-based payments. So we create an individualized benchmark for practices for each patient based on risk adjusted as much as we're able to risk adjust given CMS claims. And then we create a target price. And if you can't, for that 6-month episode of care, based on that practice's individual practice experience going back between 2012 and 2015. We trended forward based on medical inflation, unique to those specific disease categories. And then we say, how did you do for any given period of time? And if your total cost of care for that patient is less than your benchmark price, it has to be 4% less. So the first 4% in savings goes to CMS. If it's more than 4% below your benchmark price, you get a portion of those savings. And the reason I say a portion, because it's also a quality metric. So we have quality measures in the CMS, in OCM, and how we calculate what we call your performance-based payment is we take your total savings and we multiply that by your aggregate quality score. You get anywhere from 0 to 100% of your savings, based on how you did in terms of quality. So it's a matter of providing high value care. So you try to save money, but at the same time you continue to provide high quality care. And then you get a performance-based payment based on that. Now, just to take a step back, it's a little bit of a transition between fee-for-service and bundled payments, because I don't think most oncologists these days would accept a bundled payment straight out the gate. So the way it works is you get fee-for-service, and then basically straight fee-for-service Medicare, and then there's a reconciliation afterwards, a retrospective reconciliation, and then based on your benchmark payment, you can get a performance-based payment. Currently, it's one-sided risk, so you can only gain, you can't lose, and we've created some incentives for people to go into two-sided risk and accept some financial risk. So that's basically OCM, and we've seen anecdotally a lot of folks tell us that their care, they think, has improved, which is wonderful for us to hear. We got a lot of flack about the 13-point IOM care plan when we first rolled out OCM, and now we hear some cranky doctors talk to us and say, my care is better because of this IOM care plan. And so I think that's always wonderful to hear, and people talk about workflow changes and how their care has improved. So that's OCM. And so now with that, let me go a little bit to what our efforts are in navigation. And again, the whole point of OCM was not to be prescriptive. So I always say that in federal health policy, your program has to work in Wyoming and it has to work in Manhattan. And that's one of the hard things about designing federal health policy. And one of the things we realized is there's so many different business models of cancer care out there. So we thought there were 3 models of cancer care out there when we rolled out OCM. When we started talking to people, we found out there were 23. So we have to try to make it work for everyone. So that's why we were non-prescriptive in terms of providing navigation services. And that is the requirement there. We ensure that navigation is being provided to patients through site visits, which we visit practices and we see if they're actually complying with all the things they say they're doing, since we're giving them a fair bit of money through the MEOS payments. We also have an evaluation team that, as the model goes on, will look at the different types of navigation provided by the practices to sort of get a sense of the landscape, is who's doing what, how did it work out, what were the pluses, what were the minuses. And then I think the last thing I'll say is I mentioned before that the performance-based payment is based on your savings and multiplied by your aggregate quality score. One of the components of the aggregate quality score is our CAPS oncology measure, sort of a modified CAPS oncology measure, because we've added a few of our own questions, and about 5 of the 50 questions relate to care navigation. So if you are not providing care navigation services your CAP score will go down, and the amount of your performance-based payment will go down as well. So we've incentivized, we try to create that incentive for the provision of navigation services, and we're looking. Again, the nice thing is it's in 175 practices across the country. We have solo practitioners. We have Texas Oncology, which has 400 doctors. And we're going to see how they implement navigation across the country. So, thank you.
Thank you, Ron. If you don't mind, we're going to save questions and discussion for after the three speakers, okay? I know that was a lot of information, so take notes. Our next panel member is Nina Miller. Nina is the Manager of Cancer Initiatives for the American College of Surgeons Commission on Cancer. She currently serves on the National Navigation Roundtable Steering Committee, the Comprehensive Cancer Control National Partners Leaders Team, and was recently elected Advocacy Director for the Association of Oncology Social Work. During her years at the American Cancer Society, Nina was the Director of Patient Services for the Midwest Division, and previously she managed the NCI's Cancer Information Service in their regional field office at the University of Wisconsin's Comprehensive Cancer Center. Nina's clinical practice as an oncology social worker spanned over 15 years. Help me welcome Nina.
Good morning, everyone. I'm pleased to be here today and just wanted to spend a few moments with you sort of bringing the group up to speed with what's happening at the Commission on Cancer regarding patient navigation, and also to just sort of give you some of my thoughts, I'm going to say personal thoughts, if you will, about this whole concept of patient navigation that I've been working in for a very long time. And so hopefully some of these thoughts will make sense and maybe summarize some of the thoughts that we've already heard this morning. So I wanted to start out by just providing you with this quote from the recent National Academy's work that was done in November of 2017 that Lisa was in leading the way of, to just really say that it's really important that all of us get together and do some networking and make this work, a joint work. So thanks to the American Cancer Society for bringing this roundtable together, because I think it brings really important partners to the table to really address some of these things and move this movement, if you will, forward that has been around for its maturing and has been around for some time. So I think that the opportunities that we have as a roundtable are listed here. I think to inform the Commission on Cancer standards for quality care is one of the things that can be an outcome from the work that we do here. Certainly bringing strategic partners together is a critical piece of what we do, and we all learn from each other when we're in person as well as when we're on the phones and doing the work of the task groups. I think clarity of the definitions of what navigation is and what navigators are is a really critical piece of what we are working on right now, and work on the policy issues. I'm on the policy task groups, and thanks to the policy task group leaders for really, I think, doing some yeoman's work in regard to both big P and little p policy issues, if you will. I think becoming a clearinghouse for certification, training, metrics, and tools may be a possibility and an opportunity for the roundtable moving forward. And of course, not duplicating efforts of the organizations that are members of the roundtable, which probably goes without saying. So I wanted to just talk a minute about the Commission on Cancer Standard, and I'm not the only person in this room that's involved with a standards revision project, and so thanks to those of you in this room that are helping us to inform how the standard will be revised moving forward. But just to review then, the Commission on Cancer has a standard of quality care, standard 3.1 in our 2016 edition, that reads that a navigation process driven by a triennial needs assessment of the community is established to address those healthcare disparities and barriers to cancer care, and resources to address identified barriers may be provided either by the healthcare facility or by referral. So just to sort of bring you all to the same table, the Commission on Cancer accredits about 1,500 cancer programs across the country that serve about 70% of the cancer patients that are treated in this country. And we aim to really make our standards of quality doable for large cancer programs as well as small cancer programs throughout the country. And that's actually probably one of the greatest challenges of the standards as we are writing and revising them. So a work in progress for 2020, we're currently involved in a standards revision project where we're looking at all of our standards and making revisions to those standards. And we're really looking to have drafts of the standard revisions in place in early 2019, looking at some focus groups to really review those revision proposals, and then for implementation starting in the beginning of 2020. That's the timeline that has been established. Always, of course, could be changed. But that's, we're working on that kind of a timeline. So there's some subtleties to what has been in discussion so far. And this is not a sort of don't take this back to your accredited programs and say this is what we're going to be judged, if you will, on moving forward, but just some thoughts. And so please, if you have thoughts about this or comments about this, to get them to the Commission on Cancer for our consideration through a couple of us in this room. We're happy to take that back. But we're really looking at sort of taking it to a next step as opposed to a community needs assessment that's really the primary sort of piece of the standard, is to really say, okay, sit down and look at who it is that you need to put on a navigation team within your program to identify and implement a navigation plan. So a team that establishes a plan for how you're going to navigate your patients. And please do that based on your assessment of who it is in your community that is does have the greatest needs. So we're not doing away with the community needs assessment, but we're saying take that information and that data and that analysis and really pull it together and bring the people in your healthcare system together in a team to sort of look at that and say, how can we best use this information to determine how we need to navigate our patients? So the part of it that is sort of that a surveyor can look at is, yes, are you selecting specific barriers, and are you developing plans to address those barriers, and are you looking at your resources, and are you determining how specifically you're going to navigate patients experiencing the barriers, and are you evaluating the processes, of course, and reporting those back to your cancer committee at least on an annual basis. And those kinds of things will all be inclusive in the standard language, I think, moving forward. But probably the most significant change is the whole team concept and making sure that team is meeting and talking and looking at the evaluation as well as the analysis of what's happening in the community. So reporting on what resources and processes are utilized to identify and address barriers. Of course, that metrics piece that we talked about this morning is so critical and so important, and something that the oncology care model is certainly helping, to be able to inform us as well. And then, then looking at a quality improvement process as well. So the other thing that I think that the work group that is convened to look at this standard revision project is really focused in on is truly, let's not forget about the fact that we need to navigate patients in the end and help them through these complex processes, whether it's in a risk stratification model or if it's more universally available within your cancer program. So again, as I talked about, is building that navigation team. I think that we've talked about that a lot this morning already. The nurses have an important role. The social workers have a critical and important role, not only to mental health, but to resource identification, to being able to work within the community and look at those things from a systems level, at an individual level, at a provider level, and at a community level as well. Bringing the physicians into that mix as well, as they have that knowledge about patients' impact depending on their treatment plan, and then the rehabilitation specialists and all of those people that are critical to being able to get patients from A to B or A to Z, as the case may be. So just a few of my additional thoughts. I think if we're going to advance the field of patient navigation, tailoring the process to the needs of the population served and to the at-risk population in the community, whether through risk stratification or just awareness of who those people are and the barriers that they're experiencing, whether it's by diagnosis or by social determinants of health or any of those kinds of things, I think is just really important to the navigation team and how they develop their process of navigating patients within their facility. I think don't ever forget about the whole cancer health disparities, because isn't that what we're trying to do, is reduce morbidity and mortality for patients, as well as helping them feel more in control throughout their cancer experience. Prioritizing navigation services to the populations in greatest needs, I think, is critical in a world in which we have workforce shortages, and as Dr. Wender said, we're coming up on a tsunami of increase of cancer diagnosis in those of us who are baby boomers. I'm not the oldest baby boomer. I happen to be, I think, the youngest baby boomer, but I'm in that group. Paying attention to those social determinants of health, I think, are a critical piece of that community needs analysis and what the healthcare navigation team needs to look at. And working with the community-based organizations. I think some hospitals do this so much better than others, is just really outreach into who it is in the community that's doing work with these populations that are in greatest needs, or who are doing the community resource development, whether it's in transportation or financial assistance or concrete services of some kind, and working with them on gaps in resources. Navigators can't navigate patients to resources that don't exist to meet their needs. So that development of resources and addressing those gaps in resources in the community is a critical piece that we actually don't talk too much about, interestingly enough, within this roundtable work or otherwise. Again, I think I mentioned before, look at your system-based, your provider-based, and your patient-based barriers. And thanks to Dr. Freeman for setting us up with that framework from the get-go. I can't leave that be. It's still there and still on the forefront of what we need to really be looking for. And then assessing barriers, and this brings my social work background to this table, is really looking at those barriers from that micro, meso, and macro systems level, where we're looking at the individual, but we're also looking at our systems, and we're looking at things from a broader based community or even global perspective. And I think that we'll hear that from Lisa as well. So going back to the basics, I think, is something else that's important, using evidence-based interventions, doing research to add evidence to inform the field, certainly avoiding duplication, filling gaps in service provision. I think that's a duty of this roundtable as well. Navigating patients, triaging them to navigation providers based on need. That's a basic premise of patient navigation, but important, I think, to mention. And then, of course, the evaluation and the continuous quality improvement that's so critical. I think getting specific about titles, and others are going to be talking about this, and we talked about it a little bit this morning, but I couldn't be on this podium and not sort of bring this back to the group to really say we recognize that there are community health workers doing navigation in communities oftentimes that are very culturally sensitive and so critical to meeting the needs of many people. And patient navigators that are really looking at sort of resource intensive, whether it's financial resources or otherwise. There are people that have to do that kind of work. And then there's clinical navigation that's so critical to getting people through a complex cancer diagnosis. And we need to recognize all of those groups and specifically address some big P and little p issues as they relate to those three groups. So my final thoughts are really recognizing the distinctly different contributions of those three groups, facilitate the training and establishing policy about supervision of unlicensed providers, working with payers on reimbursement for providing those navigations in those buckets, and then recognizing that the navigation processes and the need to pay for the analysis, evaluation, research, training, and supervision, or somehow, figure out how we get that work done. So I want to leave you with this, just so that it's in a deck that you might have moving forward, because there are a couple of critical individuals at the Commission on Cancer that would take your input on this and other standards for accreditation as we go through this revision process. Connie Burra is the new incoming administrative director for the cancer department at the American College of Surgeons, and Aaron DeCoster is the person who is overseeing the standards revision project. And their emails are listed here, and please, they will welcome your comments on that. My email is also here. As you can see, it is not an facs.org email. I am unofficially retired, but retiring officially on January 2nd. And so left you with a couple of important staff contacts. That's all I have to say this morning. Thank you.
Thank you, Nina. So we've heard a little bit about reimbursement and quality from Ron. We've certainly touched on quality again in the credentialing process from the College of Surgeons. And now our final speaker is Lisa Sims Booth. Lisa serves as the Senior Director of Patient and Public Engagement at the Biden Cancer Initiative, helping define the organization's strategy, priorities, and programs. Lisa leads the initiative's advocacy outreach and collaboration strategies, including the design and coordination of the Biden Cancer Collaborative, which develops solutions to shared challenges. In addition, she's worked at the Faster Cures, a center of the Milken Institute, and created programs to bring together pharmaceutical, biotech, philanthropic, and nonprofit communities. So without further ado, let's welcome Lisa.
Thank you, everybody. It's great to be here this morning and to talk about this important work. I thought I would spend a few minutes, because I know a lot of people have probably heard about the Biden Cancer Initiative, but you may be thinking, what the heck do they do? And what are they doing? So I wanted to share a little bit about BCI in general, and then talk specifically about some of the work that we're doing in patient navigation. So of course, we recently had our Biden Cancer Summit. Some of you may have been there. Maybe you were able to live stream parts of it. But really the theme of and the heart of what BCI is doing is we are really trying to create a system that people think already exists. And and so we think about what is impact. And we're born out of the work of the Cancer Moonshot. And so we learned from that moonshot experience that there is impact is happening. And the moonshot was a great example of pulling together different government agencies, nonprofits, academic centers, people all over the place to say, what can we do? How can we come together? And really not simple, but this major project that started literally out of the experience that the Bidens had with their son Beau and President Obama, seeing that and thinking we need to do something, led to the moonshot. And we did have impact there. But we know now that we can't, the work isn't done And that the only thing that we do, and what we really try to do at BCI, is we shine the light on what other folks are doing. The Moonshot started that, and BCI is continuing that. So if you were at our summit, you saw that a good chunk of the day, it was other people talking about the work they are doing in cancer. And that's a really good basic tenet of the work that we do, is how do we highlight the great work that's being done? How do we pull more of those people together? Because we have to shine that light broadly, and a lot of you in this room are doing some of that work. And so, but that's how we can really maximize impact, is to share what's happening so it reaches broader audiences. So we really want to have, sorry, I want to go back to that. We really want to respond to what we see as a lack of a comprehensive and cohesive approach to both prevention, detection, diagnosis, research, and care. Now that is a lot. It's a lot. But when you work for the Bidens, you take on a lot. And so we are doing that. And they're just as passionate about it as the staff are, and just as passionate about it as I know the people you are here in this room. And so, but we always want to think about the people. And we go, and I travel a lot, and the Bidens hear these same stories. We think about the people. You may recognize this is Devin Still and his daughter Leah. He was at the summit. He's an NFL football player whose daughter had cancer, and you know, in their story, he since started a foundation. But we think about the people. And we know that as we talked about this morning with the new immunotherapies and all the different things that are happening, more and more people are finding different ways to treat their cancer, but the bottom line still remains, and what we hear all the time is that people are still confused by how they navigate this system. These words they don't understand, these treatments they're supposed to get, these appointments they're supposed to go to, how do they navigate that? What do they do? And so that is really the heart of some of the work that we're doing. And so we have 7 principles that we follow that sort of guide our work. And I'll go through them quickly as you can see them here. Share data and knowledge, ensure affordable access to care, bring patients into the system, not just a research and care system, reduce disparities, which we've talked about already, put progress ahead of personal gain. We really need to think the patient first, myself later. And when you work for folks who've been in public service as long as the Bidens have, you really learn that quickly. Find new solutions and disseminate that information. And lastly, help people navigate their cancer. And so you can see that navigation is one of our principles. And that's why it really led us to get into this work. We are really blessed to have a world-class board and an advisory committee that helps us to do some of our work. I'm excited to say that some of our board members here, Stu Schneider's here, some of our advisory committee members, Dr. Winder's on our advisory committee, Danelle is here as well. And how we focus our work is we've identified these 6 areas that we're focused on, and we have working groups that are dedicated to those efforts. You can see them here: data sharing, data standards, clinical trials, prevention, patient navigation, and cost and access. And so our advisory committees and working groups look at these issues, help us identify actionable steps that can be taken. And so each of their mandate is to figure out what can be done, how can BCI help, who are the other players we need to bring into this, and how do we move forward? You know, and so it's just really taking an issue and saying, being laser focused in, is there something we can do? There's already great work being done out here already, and so it's how do we harness that work, bring the right people together to really move it forward. So around patient navigation, we've brought together what I think is a stellar group of people, and we really did want to make sure that we were not only collaborative, but that we were really looking at the people that really needed to be in the room, around this table, so we could bring in all the various perspectives. And so I want to quickly just give a little highlight. I'm not going to go through each, but I just want to share a little bit about not why we picked them, but what perspective they bring, which is so important to the greater conversations. So Danelle Johnston is our chair from AONN, you know, one of the largest special organizations around oncology, nursing, and navigators. And we won't talk about Danelle, because Danelle's great, she's here. Crystal's also here, Crystal Duggar. And having someone like her with the corporate background that she has, they're the largest health system with the navigation system, and they're implementing that model. So she brings that perspective, which is very important. And to us, we have Beth High from the University of Arizona, an academic NCI program, so with a strong navigation program, and they do a lot with metrics and acuity, so we're bringing in that perspective. We have Clara Lambert, who's one of the, I think I would call her one of the forerunners, foremothers, if you were, of the financial navigation work, and she's part of the ACC Financial Advocacy Network. Monica Dean is on our working group as well, because we want to be connected with ACS work and what the roundtable is doing. So we're all in concert and working together. So we want to make sure Monica was involved. Trisha Shusowski is also on our board. Trisha, who's also here and part of the roundtable, leading the metrics working group. So she brings a great wealth of knowledge around the metrics and all of those kind of things. Hope Preble from Midwest Cancer Alliance. She's an oncology administrator with oversight over clinical and patient through MCA, and does a lot of work with rural and urban. So we want to have that. And of course, we have Brenda Nevajan from ONS. And Brenda, of course, brings in the care around clinical nurse navigation and clinical nurse experience. So we wanted to make sure we had her involved. And we have Kay Rice, who does work around practice, private practice and OCM model. And then we have Jenny Cruz from Seattle Care Alliance. She's a physician but she's a real champion around navigation, and she brings that background to us. And then we have Elizabeth Franklin, who's also here in the room, from Cancer Support Community, who brings a lot of policy and advocacy work, and we need that in the group, but she also has a strong social work background, so she brings that perspective. So I didn't want to belabor all that, but I want you to see the caliber of the group we brought together, but the different perspectives and experiences that are sitting around the table with us to really help us lead this work. So that's a picture of us at our meeting outside Austin when it was 105 degrees that day. Luckily, we were inside at the Dell, at the UT Austin Center. I think someone from Dell is here. But this is just, I wanted to share, this is a great picture of the group. But we came together, many of us, like for a couple of hours. And I have to say, it's one of the most amazing experiences I've seen of a group of people coming together and immediately rolling up their sleeves and getting to work. And from the day the meeting started, we really coalesced. We really came together and really worked hard and rolled up our sleeves to get to work. And so we came up with the mission of the group, not surprising. How do we get a plan that'll move us closer to having more implementation of patient navigation programs around the country? You know, what we're all trying to do. How do we make sure more patients have access to navigation? And we came up with a problem statement that we thought sort of encapsulates where we are right now with this. And that's, I'm not going to read it because y'all can read. And people hate, don't you hate when people read their slide to you when they're reading it right now? But just note that we know it works, but we know there are problems. You know, and so we've identified these problems that we think are the sort of foundational barriers to getting in our way. And that's the very definitions of patient navigation and the lack of uniform best practices, accreditation, role delineation, standardized evidence-based metrics. See, I'm doing it. I'm reading the slide and I'm looking at it. I'm sorry. But domains of return on investment, clinical outcomes, and patient experience, and of course, issues related to policy and payment that I know Ron can talk a lot about. We identified these barriers, and then we set about how do we address them. And so we sat there at this meeting and we thought, what are we going to do? And we originally thought we were going to go right to the policy payment issues. But as we started to unravel it and think about it, we came to realize that we needed to start at the bottom. And so we have this sort of our work stream, but we're working from the bottom up. And so what we need to first do is figure out the definition and then to have a harmonization from within the professional groups about what navigation definition is and the role delineation. If we can get some synergy and coalescing around that definition, then we can build up to building those trainings that we were talking about this morning and competencies and curriculum. But if everyone's on the same dance card of what they're doing, we can build those. And then we can get into metrics, reports, and benchmarks because we've built that foundation of the others. Then we can get into how do we do the resource allocation around acuity. And then finally, that builds in a policy and payment. So this is the way what we wanted to share with you. This is the model that we think can help guide. I think it works, and I think it's great synergy to the work being done with the roundtable and the working groups that already exist there. So we see this as like sort of a coalescing moment that we can all work through together. But I wanted to lay out for you the group, but also the approach that we're taking. And then finally, I'll just leave you with our, if you've seen our social media campaign, it's called Cancer Fears. And that means and in cancer, we all know, you deal with people all the time. They're scared, they're afraid, but we also want to turn the lens to those people who are being resilient and courageous in facing what they're doing, but also the work that people like you are doing, the researchers in the lab, the people on the front lines, the navigators themselves, you all doing the work. You all have a Cancer Fierce story. And for us, Cancer Fierce means we need to collaborate, we need to work together, we need to bring everyone to the table, build on our strengths, and move forward. And so I just want to say, to end this for me today, just to say, let's be Cancer Fierce, let's work together, and as other folks have said, we're at an amazing inflection point around navigation right now. We have an opportunity, and we have the right people in the room together, and I know that we can do this. And so more patients have access to this wonderful resource that not everyone's getting. So thank you.
Thank you, Lisa. You're reiterating, I think, what Tracy said when we first came in today, that now is the time. And I think having everybody in the room, having had now your second meeting where you're all together, you have an opportunity to hear from 3 organizations that are actively involved in promoting, defining what is navigation and how we can see that expand. So now let's kind of move into more of a question and answer and discussion part about what's the future of the National Navigation Roundtable and how can they work with member organizations like COC, like the Biden Cancer Initiative. How can they work within an oncology care model for reimbursement and quality for value-based care? So I'm going to open it up now to all of you. There'll be microphones. Are there microphones going around? Okay. So that you can ask your questions of our panel members.
Dr. Kline, thank you for being here. I'm Ed Partridge from the University of Alabama at Birmingham. Could you expand a little bit on the recently announced mandatory model for radiation oncology and what it's going to look like? I don't think we have any Washington Post reporters in here. And secondly, what's the future of payment reform in cancer in Medicare? I mean, Medicare, yeah, Medicare. We're not going to back up, or we're going to keep moving forward away from standard fee-for-service.
So way above my pay grade for both questions. I'll answer the first question, which is Secretary Azar talked about a radiation oncology model that we're working on. 2 paragraphs above it, he talked about mandatory models. 2 paragraphs below it, he talked about mandatory models, but he didn't actually explicitly say that the radiation oncology model would be a mandatory model. So that's that people make whatever inferences they make. I can't share with you anything additional to what the Secretary said, except there was a report to Congress in November of 2017 that was mandated by Congress about what a potential radiation oncology model might look like. And so if you have interest in some of our thinking, that's a public document you can certainly find and address. I certainly am not the one to talk about the future of all cancer payment for the government going forward. I would say what I've said before, which is, trying to make sure I have a job to go back to on Friday, tomorrow. So not an official CMS position. This is my personal position. My personal position as a physician is, I'm too young to have seen usual and customary, which I heard were great days. When I graduated medical school, managed care was coming to fore. I don't think that patients are happy with managed care. I don't think physicians are happy with managed care. So I view a world of bundles, however you want to define those, as a good thing for those of us who care for patients directly. And by that I mean, rather than someone who's 3 time zones away who doesn't know the patient saying, you can use this medicine, you can't use this medicine, what a bundle payment system does is to say, you doctor, you nurse, with a patient sitting in front of you, with all the variations for every specific cancer patient, and especially in cancer, there's a lot of variation, you decide what's best for this specific circumstance, and if you can provide high value, efficient care, we will reward you, we will incentivize you to provide that good care. So I mean, if you look at CMMI models, in the past, they've typically been bundled payment systems. I think that's the paradigm. So take from that whatever you wish. And hopefully I have a job to go back to tomorrow.
Hi, Elizabeth Rohan. I just wanted to say to Lisa that looking at your slide about sort of where are the gaps and how they map perfectly onto our task groups was really validating because, we started these task groups a year ago before we were really integrated into the Biden Cancer Initiative. And so, wow, we've been doing the work that other groups have said, yes, this is where this needs to go. And I know Tricia has been saying, where are you, Tricia? That the stars are aligning, but wow, really, really. And not that I didn't believe you. I did, but I just have to say
Glad
that
I could back Tricia up.
that was really kind of profound. So, this is great. That's all.
Hi, Lily Shockney. We've talked a little bit this morning about the silver tsunami, and I am in that group. But what we haven't touched on yet is the growing shortage of oncology specialists. So I think your job is very secure, by the way. But is there any effort within ASCO or some other organization to promote individuals to choose oncology as their medical field in medical school? Because there won't be enough of you to take care of the growing number of patients going forward.
Lily, that's an excellent question. And the National Cancer Policy Forum is having a workshop in February, open to the public, on February 11th and 12th to address just that issue. And it's not just about the workforce, it's about the care force. That not only are there people paid to take care of people facing or being treated or surviving a cancer diagnosis, but there are many informal caregivers and family members who are intricately involved in providing that care as well. And so the workshop will be addressing not only the professional staffing, but also how we train and support the informal, the unpaid caregiver in the United States.
I just add one real quick thing, which is to the extent that we allow physicians and nurses and nurse practitioners to take care of patients rather than running around trying to find scans and get people to appointments, we're going to get more value out of those clinicians. So that's where navigation comes in. I was in private practice of pediatric hematology oncology for 25 years, and a lot of my day, a lot of my nurses' days were spent trying to track down scans, track down reports. So to the extent that we can have support staff, navigators, get patients to the appointment at the right time so we're not having urgent calls, I'm here and my scans aren't here, we're going to make better use of those clinicians.
I think there's just a couple of other things that are worthwhile to mention, and one is, you mentioned it this morning, Rich, is just really looking at the unnecessary care that could be addressed in a very meaningful way. And as a social worker, I have to say the second thing is just empowering those patients who are really capable of self-navigating and empowering them to be able to do that, as opposed to, I think that sometimes it's those patients who are capable of self-navigating are the ones who demand to have a navigator, if you will. And I think that we need to figure that out. How do we empower those people to maybe even navigate others, because they're information seekers and they're people who are advocating on their own behalf, and that's fabulous. But we have to address that question, I really believe.
Can I go? I agree completely with what Ron just says. I mean, in the ideal world, and I think that world is actually coming because of payment reform, you would have a team that included the physician, an advanced practitioner, could be a nurse, could be a physician assistant, a nurse, maybe a nurse navigator, a non-clinical navigator, and a piece of a clerical person, and every patient would have such a team assigned to them, and everyone in that hierarchy would be working at the top of their professional training. So everything gets passed down that doesn't require your professional level. It goes down one level. Secondly, if bundles come, and I think they are coming, then the incredible documentation that we have to do for billing purposes really fundamentally goes away, because you've got a set amount of money for stage 2 colorectal cancer in a 72-year-old with 2 comorbidities, and you've got to deliver the care within that bundle, and the only documentation you need to do is the documentation that's necessary for high quality care. And so the world changes fundamentally. I mean, I've said this in many forums. If you were an MBA student 50 years ago and you designed the fee-for-service delivery model for the United States, you would have gotten an F, because it really has developed and is poorly designed to take care of people across the continuum of care. So I've been in medicine for 50 years, and I am more optimistic at this point, for the first time, that we actually have the opportunity to get it right. Navigation will be a big part of that, because most of what occurs in terms of sickness and health is outside the walls of the institution, social determinants of health. And so when we began to address that, and I actually reimbursed for addressing that through a bundle, whether it's a primary care patient or a cancer patient, then we've got a chance to actually have the best healthcare delivery system in the world.
I would agree with you in terms of bundles decreasing documentation burden. You know, I think one of the things that when we, actually the National Cancer Policy Forum, we're actually working on a paper. We have a writing group on how EHR should be modified for oncology, how we can make them work better. And again, as you say, the payment is what drives documentation. So in a world where there's a bundled payment, it no longer drives that. And I always say that in my next life, if you want to see how documentation works in bundled payment, look at a surgeon's note. I always say that in my next life, I want to come back as a surgeon, because their notes are, post-op day 2, no pain, passing gas, we'll see tomorrow, because they get and then we have 7 pages of documentation for a verbal order. So I agree with you 100%.
Hi, this is Angie Patterson. I'm with Georgia Core, which is the Center for Oncology Research and Education. And I have a question for Ron and also maybe Nina. So this year in the summer, Georgia Core hosted the 2nd annual meeting of the OCM practices in Georgia. And originally we had 7. So when we sent out the invitations, it was down to 6. Because so many of the healthcare systems are buying up these practices. But my question is, at the meeting, seeing the results that they were getting from navigation, reducing the cost of ER visits and that type of thing, it was very reassuring that OCM is working. But how does that fit into the COC hospitals that have their own guidelines that are buying up the practices? So how are we going to resolve the future step of payment? And that should be a simple answer, right?
I think the question you're asking is, if I understood your question correctly, is when you keep a patient out of the ER, you create value for the healthcare system, but you take money away from the hospital, if I understood your question correctly.
That's part of it.
And that is a difficult question, and actually, when we're working on a paper actually with Gabrielle Roque from UAB on navigation, and one of the she had a beautifully eloquent sentence in the paper that we're working on, which is, a bundled care payment system, you get to sort of monetize the savings that you don't spend. Because right now in fee-for-service, if you keep somebody out of the hospital, the hospital loses money, you don't get benefit. In a bundled payment system, if you keep somebody out of the hospital, maybe you don't generate the revenue for the hospital, but maybe you get that, in terms of a performance-based payment. I think that we're in a very difficult place right now in terms of healthcare transition, and the way somebody once described it is it's hard to have your feet in both canoes. This is what you're supposed to do for fee-for-service, this is what you're supposed to do for value, and you do different things in different situations. And so, perhaps getting to value quickly is the answer. Another person who I talked to about this, this transition, basically said, I talked about my two-canoe analogy, and he says, well, my analogy is you take the boat, you go across the river to value, and then you burn the boat.
I don't think that I have anything else to say to that, Angie, except I think that one of the things that many of us, the Commission on Cancer included, need to be very conscientious about is the networks that are forming of hospitals, with large hospitals taking on lots of small hospitals, and just how that is impactful on the care that's provided, hopefully in a very positive way. But I think that if we ignore that and don't think about that, that we may be doing a disservice to patients moving forward. So it's a great point and a good reminder, I think, to many of us to be conscientious, because the world is a-changing, right? It's conglomerations are happening, and networks are forming across the country, and big health care providers are in many cases doing yeoman's work, but we need to make sure that those small, maybe satellite hospitals or whatever they call themselves these days are considered as we develop policies in big and small systems. So thank you for bringing that point to the table.
I'm just going to add one thing real quick that I forgot to mention. I think one of the things that's also going to drive change are commercial insurance companies. So hospitals may resist sort of that fee-for-service type of thing. But if a commercial insurance company says, we're going to pay you based on value, that will drive change as well.
Yeah, the concept, Nina, you make a good point about the networks that are forming, but you have the opportunity in these cancer networks that might include an NCI-designated comprehensive cancer center and 12 to 15 community-based cancer centers that are practicing oncology. And you get something like a Medicare shared savings program that includes the entire network. You have a governance board that defines the quality metrics that you're going to measure this year, the cost reductions, and we hold each other accountable in the network. So at the end of the day, one could visualize that a patient with cancer could come into the network at any entrance point and be assured of high quality, cost-effective care, because we're in it together. With the silver tsunami, the volume of cancer that's coming along, there's enough for everybody to do well. We don't have to be competing with one another over volume. We need to be joining together over quality and cost reduction.
If you agree, nod. Yeah. Okay, Elizabeth has a question, and then I have a question that I think is coming up from a couple different people from earlier conversation. Elizabeth?
Great, thank you. Elizabeth Franklin with the Cancer Support Community. Lisa, this question is for you. I know there were the 4 work streams that were original to the BCI, and then patient navigation was recently added. Can you talk about the inspiration behind that and kind of, it came last, but it's super important. Was it because you saw gaps in clinical trials and data and everything else? And can you just talk about that a little bit?
Sure. I think the original 3 data sharing, data standards, and improving clinical trials really came out from the moonshot work. The vice president saw that much work needed to be done, so those continued. I think the patient navigation or idea resonated because we kept hearing all over the country, everywhere we went. I go on these tours, I don't call them tours. Dr. Biden, when she has time, we do these conversations with Dr. Biden, and we do small, intimate gatherings with patients, caregivers, but also navigators, oncology nurses, social workers. And every single meeting, it came up. I didn't know, for the patients and their families, I had no idea what to do. We were on Google. We had no idea how to handle the situation. I wish someone would have helped us. I wish we could have known there was someone to help us. And we just kept hearing it repeatedly. And then Dr. Biden, for anyone who was at the conference in Dallas, her own sister had a navigator that helped them through, people know about her sister's cancer treatment. So it just became this, like, we need to do something. Like, this issue is, people need help. How do we do this? And so it emerged that let's do this working group, and let's see what we can do to help move it along so it's accessible to more people. We know it works from the anecdotal, and we know from some data that we have, but can we do something to really make this more available to others? And that's really how it came out. Just we kept hearing it repeatedly, how much it was needed. The very first conversation we did in Austin, Texas, the first thing out of the first person's mouth was, we were totally lost and had no idea what to do. And it was just this moment for Dr. Biden. I think we looked at each other and we were both like, here it is again. And so that's really where it came from. So thanks.
So I think that sets us up nicely, because I was hearing, I think, before this meeting and getting some talk, I think, yesterday and today and I think this is going to be salient, the question for everybody in the room, is that really, I think Elizabeth had talked about, it's confirming to see that the Biden Cancer Initiative really had the same areas that really reflect the work that the Roundtable is doing. And then there's organizations who are doing this work as well. I think the question has come up is, how are we going to synergize? Who's going to be carrying the torch in one area? How are we going to be careful to not duplicate in the way that we're bumping into each other and causing confusion? So I would just ask, and I know Monica and I have had this talk, and I asked her if it was okay if I went ahead and asked this in front of God and everybody, and having Monica have the discussion as our representative from the roundtable to start us off, to talk a little bit about what are we seeing as the opportunities, and then how are we really going to just be careful to not cause this confusion. So we'll start here, but I'd love to hear, Lisa, your thoughts. I know Crystal, Danelle, others have a lot of different, and then other organizations. We have enough time, I think, to have part of this conversation. So do you want to go ahead and start us off, Monica?
Yes, and thank you for putting me on the spot.
I'm
I was
Oprah
hoping
today.
not to
That's
talk really the entire day. But no, so Lisa and I and Danelle and everybody that's on the working group, we've had a lot of conversations of how are we sort of going to coalesce this work? Because as Elizabeth confirmed, as the slides confirmed, I mean, the gaps are the same. We have the same alignment of gaps. And so it is, yes, very reaffirming the work that we set out to do is the work that we need to do. I think that we are still, to be really frank and honest, we're still trying to figure some of that out, as how are we going to align. I think for the synergy of the roundtable, we are not going to duplicate our member organizations' efforts. What are we going to do? We're going to maximize what each other is doing, because none of us, one organization can do it all to fix navigation, to sustain the program. So, I don't want to say that communication is going to be the success for this, but it really is. And I think having the concerted effort that Lisa and that Danelle sort of sought out, a lot of the individuals that we have, both on the roundtable and then this working group, will help us move this work forward. We sat down at the AONN conference and said, we don't want to be deliberate and say, you're going to do this work, we're going to do this work, because that's not going to be effective. But it's how can we, again, just maximize one another's leadership roles, and then maximize what resources we have at the table to give us the biggest strength. So I realize I didn't necessarily answer it because we are both sort of in our infancy. You're about a year old and we're about 2 years old. So we're kind of growing at this together in partnership.
No, I would echo to what Monica said, and we want to be as collaborative, open, honest, continue, and I think communication will be the key. The bottom line here is we want to get more navigation opportunities out there to patients, period. So how do we do that? How do we do that together? And I think we're gonna, let's be honest, it may be a little bumpy. We may have some uncomfortable conversations. I will be ready for those, and I'm sorry about them already. But we may have them. But that's okay. This is important work, and it needs to be done. But we're going to be committed to what we need to do, and I think there are going to be ways that we can feed off of each other. I mean, I think as soon as we finish some work that we're doing around the definitions and all that, like that will further inform the work you've already started. And similarly, I think some of the work that the task groups are doing will inform the work, some of the things that we're doing. So I think we're just going to have to be open and honest and willing to be uncomfortable at some points and know we're just going to have that happen. But the commitment is there for this to work. And I can say that completely personally, and I know that Danelle feels the same way. We want this to work, but ultimately we want to succeed. And I know you all do too. And I think as long as we both remember that, we'll be okay. But if someone has a discomfort and you hear something, come find me. I'm happy to give my card to anybody. I didn't put my email on, but I'm here, I'm available. I'm sure you can already tell I'm real approachable. So but really the commitment is there for this to work and to work collaboratively and in concert as much as we can. I think we have the ability to be a little nimble and let's come on, Biden in front of the name will maybe get us some places that the roundtable can't. And I think we can maximize where that works and where maybe it's that you all could do that differently and better. And, and we'll just continue to be talking and working. But I think as long as we keep the goal in mind solely, we'll get there.
So you have an incredible opportunity that the federal government has given you starting in 2016. The federal government said 175 practices, 150,000 patients, 20% of all cancer patients in Medicare getting fee-for-service. You must provide navigation. We're not telling you how, just do it. We don't want to be prescriptive. So you have 175 practices out there, geographically diverse in terms of size, who are all undertaking navigation. And we will, as part of our evaluation, look at navigation, but it's going to be just one of many things we look at. You have this incredible opportunity to go to those 175 practices and say, how have you chosen to interpret navigation for your practice, for your unique set of circumstances, for your patients, risk adapted, not risk adapted, and learn from that. And that's just an opportunity that shouldn't be wasted.
And I'm just going to say that I think maybe some people in this room are thinking, I think the roundtable is really fortunate to have you here, Dr. Kline, and representing CMS and representing that whole piece of what's happening in this arena. And the question that I have for you, if I may ask a question, is how can the roundtable or the Biden Cancer Initiative or any of the people around this group sort of be impactful with what the quality metrics are that the oncology care model is looking at as they pertain to navigation, or how can your work in bundled payment be informed by some of the work that's being done here, if at all?
I mean, we're always happy to meet with folks who want to share ideas with us. And so if you have ideas you'd like to share, we're happy to meet with you. Welcome to the federal government. We can't ask you for specific input on specific things, because if we do, we run afoul of the Federal Advisory Commission Act with all of the administrative encumbrances of that. So things I get to learn in the federal government as an employee. But we're happy to share with folks. I mean, in terms of, so yeah, that's probably the best way to say it.
I have a question. I am voicing this for Dr. Roque and myself. Did I say your last name right? Okay. If we wanted to take you up, Dr. Kline, on your suggestion, which is very well taken, would you help to introduce us so that we could engage with those practices in order to pursue the knowledge that you suggested?
No. No, let me be, again, I mean, I sometimes take a step back from my federal government role and appreciate all the all the things we can do and all the things we can't do. So we have an evaluation contractor that has been assigned that task. We can neither endorse nor recommend any particular institution, organization. We don't pick winners and losers. So we can't help you. There is a list of all the participating practices on the OCM website, and have at it.
I just wanted to share, I'm Marie Richards from the University of Michigan Rogo Cancer Center, and we are an OCM site, and so I'd be happy to give you the list of everybody that we meet with. Yeah.
And I'm sorry, just if I wasn't clear, the list is publicly available. It's on our site. So that's not unique to practice. It's there. It's just we can't make the introduction.
Tricia? I know, I was like, Tricia, I think you should ask a question.
So we keep talking about the time is now because, you know, a lot of us have been doing this for a very, very, very long time. And I really believe if we don't get it right this time, we're not going to get this opportunity again. I truly believe that. And we have a lot of energy going on right now. So I'm just looking around the room. You know, we got OCM, we got ACS, we got BCI, we got ONS, we got AON, we got Community Support Services, we got COC, we got, you know, AOSW. What do we do? Do we ask to create an et cetera? Do we get us consortium together? What could potentially be done so we don't leave here just saying, yeah, we're going to support, yeah, we're going to have some synergy. You know, not that anybody has to take lead because we have the leaders, we have a lot of the leaders sitting right here side by side with us. Does anybody have any ideas so that we can really put something into action and not leave here saying, yeah, we're going to work together, but we're not really sure what that is? I know I'm putting everybody on the spot, but I'll take any ideas because I'm really excited. I know a lot of people are, but I don't know what the answer is either. But more brains the better, I always say. Let's work smarter and not harder because we've been working harder for a long time, and this is it. Anybody?
This meeting in its current iteration was actually inaugurated over 8 or 9 years ago in Washington, D.C.
Agree.
Originally entitled National Patient Navigation Consortium. And some progress had been made, and then things sort of drifted a little bit, and bringing this group together a few years ago was an attempt to reconvene what originated as a consortium. So perhaps the consortium model would be a good way forward, to keep bringing all of these stakeholders together in open dialogue.
I think this is a great discussion. I guess my question is, what will a consortium do that we can't do without a consortium? What does that mean? I mean, does that mean bringing more funding? Does that mean, I'm not clear what that really means. And kind of what is it that we want to accomplish? I mean, that's probably a big question, and I don't have any answers to that, but I think we have to be clearer in some respects about what do we want to see 5 years from now? What is that vision? And then I think that helps us to figure out what are the right mechanisms. I think you're right, we've got everybody in the room, and I think everybody's at a place of great commitment, and we don't want to lose that. But I guess I'm struggling a little bit about what are the mechanisms we need in place for that vision?
So, Linda.
I set you up.
So we're all talking the same talk. So we're talking role delineation, we're talking training and certification, we're talking policy, we're talking metrics. We're all working on that. So that's what I'm saying. We bring these mighty powers, bring it all to the table in whatever venue that is. We all bring our stuff and we either kick it out or, we got to make those minimal standards in regards to role delineation, minimal standards in regards to metrics, minimal standards in regards to all of these different things we're talking about, certification and training, because we have that information. We have it right now. I think we could actually bring that information to whatever that forum is very quickly, but we have to have some decision making. What's that going to look like?
Yeah, I mean, these are really interesting and critical questions. And bear with me just for a moment to give some observations about this organization, the roundtable model. So I don't think, in my own view, that consortium roundtable is just word. And this is a group of organizations and leaders. And this is a model that the American Cancer Society has created around. We have 4 national roundtables. And I won't go into the depths. The oldest one is the National Colorectal Cancer Roundtable, which is 21 years old. And what differentiates a roundtable from an annual meeting, because I was struck, the words that struck us when we leave here, those words struck me. Because what differentiates the roundtable model, in my view, is that it's a sustained organization. It's not an annual meeting. It's a sustained, lasting, standing organization that works throughout the year, that has full-time staff assigned to it, resources put into it, driven by steering committee and task group work. And I can tell you the track record of our other roundtables, and it's not about ACS, it's just about the chance to put some resources to bring organizations together who work throughout the year, not at an annual meeting, to solve an important problem. So, we launched 80 by 18 for colorectal cancer screening, when I can show you the outcomes of that. They're published now. Incredible. Now Mission HPV cancer free. So I agree with you, navigation is unique and tougher because there are different aspects of the navigation experience. There are going to have to be some tough choices made about which specific angles we want to tackle and have a sustained effort for. And I think that should be the work of this group. And it may not be at 3:30 today, we may not have the answer to that, but then I think there has to be a commitment to continue to convene, to dial down what are the 2 or 3 initiatives that we all going to commit to and get to, and with Biden and with everyone else. But I feel, just from my own personal bias, I'm very comfortable that this is the right group. I don't feel we would need to retitle it, rename it, reconvene it. I think we have the Biden initiative, we have the roundtable, there's resources there, there's staff there. I think we got to push it.
And just to affirm what Rich is saying, I work in comprehensive cancer control, so I have a state coalition of over 70 organizations in Kentucky that I try to get to work together on common goals. That's at the state level, this is at the national level, but some of the principles are the same in that the roundtable and coalition work is really a philosophy of playing nice and sharing your toys. And it's about coming together, committing to coming together regularly. When you come together, be completely transparent about what you and your organization are working on, and be willing at times to say, well, it might not be my organization that gets the credit for that in the long run, and maybe that's okay for this project. And that's what I see happening in the colon roundtable, and is people, committed to a vision, which I find patient navigators to be ridiculously committed to helping people. So I guess I would challenge us to keep that philosophy in mind of playing nice and sharing our toys as organizations, but also to respond to calls from people like Monica when they say, what is your organization doing so I can put it here in this booklet? Because part of what we do at the state level is a survey we called Who's Doing What? So I would challenge us for the Biden cancer initiatives have, 5 goals. And if NNRT has 5 goals, what is ONS's 5 goals or whatever, 3 goals, 1 goal about patient navigation? What is AOSW working on for patient navigation very specifically? And then crosswalk those so that we don't come to a meeting and say, I had no idea that they were already doing that, or that they were going to meet with the congressman about that. What if we had all gone together to meet with that congressman? And so I just think the power of the collaborative. Don't give up.
So I'll just add a few comments to that. Those excellent comments. I think that we do have the right people at the right time, and I really like your analogy of sort of playing in the sandbox, because I think that's critical. I think there's an angst in all of us to sort of have the answers right now, and I don't think that it is realistic to think that we're going to have the answers, but rest assured that we are committed longitudinally to sort of working together to figure out what the right answers are. So that's all I'm going to add.
And I would also add that I think that hearing from Monica and team who are sitting with Biden initiative, all of the other initiatives that are happening, I mean, I think real time I hear updates about who's doing what that meeting looks like. There is cross-pollination. Monica is on that roundtable. I mean, there's all the groups, it feels like we are. And so I would also just say that I think the conversations are timely, that when there are opportunities and we are connecting, the National Academies meeting, all of this sort of work, they really aren't standalone. I think we are going to, the idea, Monica, of communication is going to be key. But I will say that I have been really excited about hearing all of the real-time updates from the leadership within the roundtable, and also I just want to also affirm that that is happening and they aren't truly standalone initiatives. So, are we done? Lisa?
Okay. Well, thank you everyone for your comments, your thoughts about what is currently going on. Thank you especially to our speakers. Can we give them a big round of applause? I know they're here all day, and we have an opportunity at lunch to kind of continue to meet and greet and discuss the opportunities going forward. So thank you all very much, and thank you.
And a special thank you to Lisa for moderating our panel. Thank you. This conversation really sets us up nicely for our final session later in the day, when we talk about the concrete sort of things we're going to leave here, sort of thinking about what our next steps are. So keep your notes handy for that conversation.